Dr. John Kitzhaber was born in Colfax, if you didn't know that, and he moved to the state of Oregon at age 11. He graduated from South Eugene High School and Dartmouth College. He returned to the state of Oregon to study medicine at the University of Oregon Medical School, which is now known as Oregon Health Sciences University. After receiving his medical degree in 1973, he moved to Denver, where he served as his internship at General Rose Memorial Hospital. He returned to Roseburg, Oregon, and practiced as an emergency room physician from 1974 to 1988. His experience as a doctor and public policy leadership on healthcare issues have established Dr. Kitzhaber as one of the nation's most respected voices on healthcare reform. He's a veteran lawmaker in the state of Oregon, in both bodies of the state legislature in Oregon. As you know, he was a two-term governor from 1995 to 2003, and he's back in politics seeking a return to the governor's mansion. Dr. Kitzhaber's visit tonight is unrelated to the campaign. He's here because, as we just mentioned, he's one of the most respected voices on health policy and health reform. And as I mentioned at the top, it's been the mission of Kadlec Health System to bring to our community health policy leaders from around the country to provide a context of this important issue. Because not only have we invited members of the community to come learn, we've also invited some members of our colleague hospitals from throughout the region, their board representatives, their executive leadership to come here as well and learn and hear from Dr. Kitzhaber as well. Dr. Kitzhaber is active in a number of national health policy and health governance organizations. And as we mentioned, we are very glad to have him with us tonight. Please join me in welcoming Dr. John Kitzhaber.
Thank you. Thank you very much. I appreciate Kadlec Health System having me out here today, and particularly your CEO, Rand Wortman, for his hospitality. As was just mentioned, I was actually born in Colfax. It was sort of an accident of history. My parents were grad students at Washington State, and they apparently didn't have a birthing facility there in 1947, so my mother was rushed across the Palouse just in the nick of time to be born in Colfax. I'm very glad to have the opportunity to be with you tonight in the aftermath of the passage of some very historic healthcare legislation by the United States Congress. And what I'd like to do this evening, and we'll leave plenty of time for an active dialogue with the folks who've come here, I'd like to talk a little bit about what the healthcare reform legislation is and also what it isn't. I'd like to talk about the tremendous opportunity that this legislation affords for strong state and regional reform efforts. And finally, I'd like to talk a little bit about the urgency of states and regions taking control of the healthcare debate in the next 2 to 3 years. The urgency that I speak of is directly related to the aging of the baby boom generation, 78 million people, 30% of the U.S. population, and they will begin coming on to the Medicare program in January of next year, with huge fiscal implications for our healthcare system. Currently, the United States has a national debt of $12 trillion, and that's going to go through the ceiling when us baby boomers come on the Medicare program. Now, to a nation that's become acclimated to big numbers, $700 billion to bail out Wall Street, $787 billion for the stimulus package, a few $1 billion for the auto industry, a few more $1 billion for the Gulf Coast. It's easy to lose track of how big $1 trillion is. So I want to give you a little exercise to do when you get home, because $1 trillion is so profoundly bigger than $1 billion that it's impossible to appreciate without some frame of reference. I call this exercise zeros matter. So get out your calculator and do the following exercise. 1 million seconds ago was last week. 1 billion seconds ago was about 1972. Nixon was leaving the White House. 1 trillion seconds ago was 30,000 BC. We've got a $12 trillion national debt, and when the baby boom generation fully retires on the Medicare program, the projected unfunded entitlement is $70 trillion. And we're planning to pay for that by borrowing money from China and Japan and other countries that are still willing to purchase U.S. securities, giving huge leverage to some of our major international competitors, threatening the fiscal stability of our government, and leaving a huge cloud of debt for our kids and grandkids to pay off. Now, within this staggering fiscal context, let's look a little bit at the national health care legislation by asking ourselves, what is our purpose here? Why are we having a national health care debate in the first place? And I would argue that the objective of our health care system is not simply to finance and deliver medical care. The objective of the health care system is to make people healthy. In other words, health care and health are not necessarily the same thing. Health care is a means to an end, not an end in itself. It has no intrinsic value outside its relationship to a health outcome except as an economic commodity. And it's very, very important that we recognize the difference between health and health care as we try to resolve the crisis that faces us today. Now, I think that Dr. Don Berwick, who is the president and CEO of the Institute for Healthcare Improvement, has captured that important concept in what he calls the triple aim, which to me offers the most cogent and elegant set of objectives for the U.S. medical system. First of all, to improve the health of a defined population. Secondly, to do it at a lower cost, to reduce per capita cost. And third, to improve the patient experience in terms of clinical outcomes, patient satisfaction, patient safety. Now, it's important to note that nowhere in the triple aim is the word healthcare mentioned, which means that healthcare is important only to the extent that it can actually advance those system objectives. The problem with the debate that we've witnessed over the past year in Washington, D.C., is that it's been focused on health insurance reform, not healthcare reform. And those are two fundamentally different things. In other words, the concern and the focus of the debate has been about how we pay for medical care, not about what we're buying and what relationship that expenditure has to actually improving the health of the American people. Now, there's some good news and some bad news involved in all of this. The good news is that the legislation that passed will dramatically expand access to medical care for millions and millions of Americans, which is very, very important and a very good thing. Secondly, it's projected that this legislation will save $143 billion over the next 10 years, with additional savings in the 10 years that follow. That's the good news. The bad news is that $143 billion isn't even a drop in the bucket compared to a $12 trillion national debt, and it's not even going to be a speed bump to this economic and demographic tsunami that's overtaking us when 78 million baby boomers come onto the Medicare program. And I'm convinced that if nothing changes, if all these hundreds of thousands and millions of people who now have coverage are dropped onto our current delivery system, the delivery system is going to collapse. The problem here is that we're operating from a fundamental misdiagnosis of the underlying problem involved. And to illustrate that, let me give you an analogy by comparing the performance of the U.S. healthcare system to the performance of an automobile. And just bear with me a minute. We all know that every car has a maximum speed. So you can take your Porsche or your GMC pickup or your Volkswagen out to the Bonneville Salt Flats and put the pedal to the, or parts of I-84, and put the pedal to the floor, and pretty soon that car will get going as fast as it's going to go. It's going to reach its maximum speed, right? Now, if you don't like the maximum speed, what can you do about it? You can yell at your car, see if that works. You can file an incident report with somebody. You can offer your car an incentive. You can go to Senator Murray and ask her to put in a car owner's bill of rights. But guess what? The car's not going to go any faster. There's a reason a Porsche goes faster than a Volkswagen. In other words, the maximum speed is a function of the car itself. It's built into the car. And by the same token, the poor performance and inefficiency of the U.S. healthcare system is a function of the system. It's built into the system, and that's not going to change just by changing the way we pay for it or throwing more money at it, which is essentially what happened in the federal health care reform legislation. Now, this becomes obvious if you stop for a moment and look at those factors that have the biggest impact on people's lifetime health status. And you will notice that 40% are lifestyle and behavioral issues. 15% are socioeconomic issues, which have a profound impact on the ability of people to make healthy lifestyle choices. Some are environmental issues, 30% are genetics. Only 10% has anything to do with the U.S. healthcare system. In other words, 90% of what keeps you healthy has nothing to do with healthcare.